Good evening, everyone. Today's presentation is on the diagnosis and management of malaria. In today's presentation, we are going to cover about the etiology and pathophysiology of malaria, the clinical manifestations, the disease spectrums, the anti-malarial agents that are available in Bhutan, and the management of malaria based on the guideline-driven protocols that are protocols A, B, C, D, and E in Bhutan. How to do directly observe treatment for those who are being treated at home, G6PD testing, and towards the end, we will cover a little bit about case classification and prevention of malaria. Malaria is an infection caused by protozoa called Plasmodium. There are different types of Plasmodium, and in Bhutan, the common ones are Plasmodium vivax and falciparum. To understand the pathophysiology of malaria, we need to know about this cycle where there are two stages of the malaria cycle. One is in the mosquito stage and the other one is the liver stage. In the mosquito, it starts when mosquito takes a blood meal from an infected human, where the malaria Plasmodium enters into the mosquito. It goes through a stage of maturation, and after a certain period, and when the mosquito bites the next human, it transmits the plasmodium into the next human. And here in the human stage, there are two stages. One is in the liver, where the parasite grows. Parasite grows in the liver. It matures and then it exits through the liver, and it infects the red blood cells. And then after a certain period, it grows in the red blood cell, and then with this rupture of red blood cells, and then it goes on to infect the next generation of red blood cells. And some of the malaria parasites would remain dormant in the liver, and they're called as hypnozoids. The clinical features of malaria appear in humans after the level of parasitemia reaches a certain threshold, and in Plasmodium falciparum, many of the clinical features are as a result of sequestration and rosetting. In terms of the incubation period for Plasmodium vivax, it ranges from 12 to 17 days, and for Plasmodium falciparum, 9 to 14 days. But we need to know that in Plasmodium vivax, PV, you can have a relapse of malaria with similar symptoms because of the hypnozoids that remain hidden in the liver. The clinical features also depend on the parasite species, the epidemiology, how endemic it is in your place, and also the age. It is always important to know the high-risk groups where people are residing in the endemic areas, for example, certain geographic areas in the world and in the southern belt of Bhutan, and those who have traveled to high-risk areas. The clinical manifestations of uncomplicated Plasmodium falciparum malaria include fever, malaise, fatigue, headache, anorexia, which are common symptoms of a febrile illness. In children, even without complication, they might have febrile seizures. In Plasmodium vivax, ovale, and falciparum, you will have fever every other day, and in Plasmodium malaria, you will have fever every third day. Now, some of the features of severe Plasmodium falciparum malaria include seizures, hypoglycemia, severe anemia, pulmonary edema, acute kidney injury. You might have ARDS-like picture, septic shock. And this means that the parasitemia has remained there in the patient for a long period of time, and time is of essence in establishing the diagnosis and providing the appropriate treatment. According to the malaria treatment guideline in Bhutan, a suspected case of malaria is in a resident or a person who has traveled to an endemic area who comes with fever or having history of fever with no other cause. And we label it as a malaria case when there is pathological confirmation that can be either through rapid diagnostic tests or microscopy or polymerase chain reaction. Now, for malaria diagnosis, test that's easily available is the rapid diagnostic test, where usually it will have two lines that will show PV or PF. For PV, they are testing the parasite lactate dehydrogenase. For PF, you're checking for the HRP2 protein. In addition to the rapid diagnostic test, we should do peripheral blood smear both the thick and thin films that will tell us the stage of the parasite development. You can have count the parasite and give the parasite density. In addition to this, we have PCR, polymerase chain reaction for malaria, that is available at the Royal Centers for Disease Control in Thimphu. For this, the samples that you need to send are the dry blood spot or whole blood. Now, for all the patients who come with fever and who have in whom you suspect malaria, it is recommended to screen all cases for malaria. And if your clinical suspicion is high, you can still go for retesting of malaria. This is because sometimes if your the parasitemia was very low, or your rapid diagnostic test might come out negative. This is a typical malaria test report that peripheral blood smear report that is available. But this is a screenshot from one of our patients in Gelipu. Here in the left-hand side, you have malaria smear that was positive. They have counted the parasite count. Then there was in that amount of field, there were 206 in terms of parasite count. On the next day after treatment, the parasite count has decreased and the smear is still positive, but the count has decreased. And here you will see one important test that has been done here. The G6PD level is 5.4 units per gram of hemoglobin. We'll discuss about this in the subsequent slides. For the management of malaria, we need to follow the guideline, the 6th edition issued by the Ministry of Health in 2024. The basic principles of treatment of malaria includes early diagnostics, prompt and effective treatment. This is to prevent mortality and achieve good outcome in the patient. For any type of malaria, you have to give at least 2 effective agents. It has to be a combination therapy. You'll have to give appropriate weight-based dosing. The objectives of treatment is to get a cure of the to establish cure in the patient where the symptoms resolve and all the asexual blood stages of the parasite are eliminated. In addition to that, we need to give treatment to achieve radical cure that will eliminate the latent liver infection where the hypnozoites are eliminated. This is important for preventing relapse in Plasmodium vivax and in ovale. The basic steps in the treatment of malaria are that you should have to do baseline evaluation, that is a complete blood count, renal and liver function test. If it is Plasmodium vivax, you have to do a G6PD testing, and you will have to rule out pregnancy in all women of childbearing age. In terms of which protocol to follow, our guideline has simplified it as protocols A, B, C, D, or E. We'll come to this in detail in the subsequent slides. And after you have initiated the treatment, we have to evaluate for clinical response, where fever resolves, patient's general condition improves. And importantly, we have to repeat the malaria smear every day so that we are able to follow the parasite clearance, or over the days, the parasite in the peripheral blood smear, there should be clearance of the parasite. And we have to monitor for the adverse effects of the medications. Before we go on to the actual protocol, we need to understand about what our guideline recommends as the first line, which is the recommended by the national guideline. And if things don't work out, where there's a treatment failure, patient persists to have fever, there's no clearance of parasite in the peripheral smear, or if there is reappearance of the symptoms of parasitemia within 28 days of treatment, then we'll have to go for the second line treatment. So we need to know what are recommended in the first line and in the second line treatment. Globally, there are many antimalarial agents that are available that target the liver stages, the dormant, non-dormant liver stages, that target the gametocytes and blood stages. But in Bhutan, in our guideline, we have simplified it. For treatment of malaria, the national guideline recommends 5 protocols. Protocol A for uncomplicated vivax, Protocol B for uncomplicated falciparum, Protocol C for mixed malaria where there's mixed infection of vivax and falciparum, Protocol D for malaria in pregnancy, and E for those with severe falciparum malaria. This is the overall schemata for the management of patient, where if you detect the malaria based on positive RDT, it must be subjected to microscopy to assess the parasite stages. The guideline recommends admission for a minimum of 3 days, but if you're in a primary healthcare center or if there's plenty of beds, hospital beds in your hospital, you can keep the patient for the entire course, duration of the course required. And based on the patient's, based on the diagnosis, you will deliver protocol A, B, C, or D. Or if it is severe malaria, you will initiate protocol E. You will provide the emergency cares. We will provide the anti-malarial and refer to a higher center. But for all others, it is expected that it can be managed even at a primary healthcare center, where you will do follow-up after you have initiated the treatment. You will do a follow-up blood film on day 1, 2, 3, and day 28. And if it's for Plasmodium vivax, you will have to do the smear at 3 months and 12 months. And if things come out negative and if patient gets improved, then you will classify as a positive outcome. But if the symptoms reappear, if there's this persistent parasitemia in this smear, then you will have to check for then you'll have to think about recrudescence or resistance, and in this case, you will have to go for second line treatment, or in this case, it's better to refer the patient to a higher center. Now coming to the details about the protocols for uncomplicated Plasmodium vivax malaria. The guideline recommends you to admit the patient to the hospital and then deliver. The drug of choice here is chloroquine and primaquine. Chloroquine you will give at a dose of 10 milligram per kg on day 0 and day 1, and then reduce half the dose to 5 mg per kg for on day 2. If it's for children, there is this chloroquine syrup that's available. For vivax malaria, you will have to give primaquine. The dose that is recommended by the 2024 guideline is 0.5 mg per kg once a day for 7 days. So chloroquine comes in the tablet of 250 milligram or 150 milligram of base, and primaquine comes in a tablet where the strength is 7.5 milligrams. Now the protocol here says that, so let's go by the adults first. In protocol A, there is chloroquine 4 tablets on day 0 and day 1, and then another halving of the dose, 2 tablets on day 2, and primaquine 4 tablets 0 to 7 days. And as the weight for younger children, the number of tablets required as per age category or weight is shown in this table, and primaquine is to be given only for children older than 6 months of age. One key important factor while delivering primaquine is the concern that in persons with G6PD deficiency, primaquine leads to hemolysis. G6PD testing is available through the malaria labs. You put a capillary 1 drop of blood on this strip and put it into the machine here, and it will give you the reading. Please remember that this is available in malaria lab and not in the general lab. Therefore, as of now, the test kits are only meant to be used for patients with malaria receiving primaquine. And however, if you're in a center where G6PD testing is not available, then you actually guideline allows you to deliver primaquine in a supervised therapy. As a result of primaquine, if there is hemolysis, there will be dark colored urine, pallor, fatigue, shortness of breath, jaundice. These are the symptoms. And in your laboratory examination, you will have decreasing hemoglobin. Now, if there is G6PD deficiency, then we cannot give the high dose primaquine. Whenever you're going to do G6PD testing, please counsel your patient about the test that you're going to do, and then the main concern that primaquine may cause hemolysis, and if there is hemolysis, usually what you need to do is to stop the medication, because primaquine has a half-life of up to 8 hours, and after you have stopped it, usually the ongoing hemolysis stops. However, if the hemoglobin is less than 7 or hemoglobin is less than 9 with ongoing bleeding, you may transfuse the patient with whole blood or packed red cells. However, despite the hemoglobin being a little bit lower between 7 and 9, without ongoing management, there's no need for transfusion, because after you have withdrawn the drug, the hemolysis stops. Coming on to management of uncomplicated falciparum malaria, you need to admit the patient. The drug of choice here is artemether-lumifantrine, which is a combination dose. First dose, you need to give stat, and then second dose should be given after 8 hours, and then subsequently BD dosing for a duration of 3 days. And in addition to this, you have to give primaquine the same dose, 0.5 mg per kg, as an anti-gametocyte agent, but this will be a single dose, and there is no need for G6PD testing here. For adults, as per our national guideline, you will give coartem 4 tablets at stat and after 8 hours, and then BD dosing for 3 days, and then primaquine as a stat dose. And for those with lesser body weight and for children, it's shown in this table. And the same caution, primaquine is to be given only for children who are older than 6 months of age. How effective is artemesin? You can see that, and then how soon are you expecting parasite clearance with artemesin? You can see in this graph that after you have given artemesin in between about 2 to 3 days, the parasitemia is cleared by about 80%, and about 3 days, smear should become negative. If there's a co-infection of Plasmodium vivax and falciparum, it's a combination between protocols A and B, and the duration is for 7 days. Here we'll start with again adults. You will give coartem at the same dose, stat dose after 8 hours, BD dose for 3 days, and then primaquine 0.5 mg per kg once a day for 7 days. And for those with smaller body weights, you can follow this table. Now, if there is no parasite clearance, or if you are suspecting resistance, both for falciparum and vivax malaria, the guideline recommended second-line agent in Bhutan is dihydroartemisinin and piperacin, which is given once a day for 3 days. For adults weighing more than 25 kg, this is the dosing. And for children less than 25 kg, this is the dosing where the dose of piperacin is slightly higher in children. And as per the body weight, you can follow the table that is given in our guideline. Malaria in pregnancy is a very important condition because it has risk for mother and fetus. For the mother, mother will have higher risk of anemia and severe malaria, while the fetus will have risk for low birth weight, pregnancy loss, and death. The safety of malarials is not tested. There's no robust evidence for pregnancy, and primaquine is contraindicated during pregnancy and lactation. So as per protocol D of our national guideline, if it's a malaria in pregnancy with vivax, you will give chloroquine, 4 tablets on day 0 and day 1, and 2 tablets subsequently on day 2 onwards, and then weekly till the baby is 6 months old. And after the baby is 6 months old, then you will give primaquine 4 tablets daily, that's 0.5 mg per kg for 7 days. If it is an uncomplicated falciparum malaria, then you can give coartem, artemether-lumifantrine, at the same dose and frequency, where you will give at a stat dose after 8 hours and BD dose for 3 days. And if it's a severe malaria in pregnancy, then we will recommend you to follow protocol E. Now, what are the features of severe malaria? Usually it occurs in falciparum. The features include loss of consciousness, seizure, they'll have hemoglobin less than 7, severe anemia, they can have respiratory distress, ARDS, acidosis, acute kidney injury, they may have abnormal bleeding, DIC, and shock. The mortality without treatment with severe malaria is 100%, and with treatment, it comes down to 10 to 20%. Therefore, our aim with severe malaria is to provide appropriate treatment and prevent death. How do we manage severe malaria? We have to do the initial assessment of ABC and resuscitate the shock, the sugar, correct the shock, correct sugar, and then we will do basic laboratory testing to check for organ function status. We will have to deliver the anti-malarial therapy. We'll come to this in the next slide. We'll have to manage the other complications. We'll have to monitor the vitals, and it is recommended that patients with severe malaria be referred to a higher center after you have stabilized the patient at your district center. In terms of assessment, you'll have to check the temperature, pulse, BP, respiratory rate, saturation, capillary glucose, monitor the intake and output, and perform a systemic examination. In the laboratory testing, complete blood count, renal and liver function test, the venous blood glucose, do a chest X-ray if it's available. And now that we have many medical officers who are trained in POCUS, please do a POCUS of lung and abdomen. For severe malaria, the drug of choice here is intravenous artesunate. If IV access is there, give IV. Artesunate can be given as IM. We have second line artemether and quinine, and it is recommended that in severe malaria, all antimalarials should be given in parenteral route for first 24 hours, and then subsequently can be converted to oral antimalarial when the patient is able to consume orally. After you have converted from IV to oral, for the completion of treatment, it is recommended to give artemether combination therapy for 3 more days. Here, IV artesunate comes with its own artesunate here and its own special liquid, the solution to dissolve it. We'll come to this in the subsequent slide. So the second line agents are here, artemether, IV quinine, and oral quinine here. The protocol E of a guideline tells you that the drug of choice, the first line of treatment for severe malaria is IV or IM artesunate. And let's go by the dosing here. For all adults and for children more than 20 kg, the dosing is 2.4 mg per kg body weight. For children less than 20 kg, the dosing is 3 mg per kg body weight. Now this has to be given stat after 12 hours, and then becomes after every 24 hours OD dose until the patient is able to take orally. Once the patient is able to take orally after maybe 2 to 3 days, then we will complete the treatment with the administrator giving 3 days of artemether-lumifantrine combination therapy. Now, how do we prepare IV artesunate? IV artesunate should be first dissolved in bicarbonate. This is the special liquid that it comes with. If your vial does not have bicarbonate, then any ampoule of sodium bicarbonate that is available in the ICU or ER can be used, and then this can be subsequently dissolved in dextrose 5% solution and administered to the patient. So this is the SOP given in our guideline, where artesunate is first dissolved with sodium bicarbonate, then dissolved in dextrose, and then it is given to the patient as a slow bolus at 3 to 4 ml per minute. The second drug of choice in protocol E, as per our guideline, is artemether. It can be given as IM. The loading dose is 3.2 mg per kg, and then it can be given as a maintenance dose of 1.6 mg per kg. And subsequently, when the patient is able to take orally, please convert the patient into coartem. The third drug of choice for severe malaria is IV quinine. IV quinine has to be given with a loading dose of 20 mg per kg body weight, and it has to be dissolved in D5 because it causes hypoglycemia, so better to dissolve in D5 and give as an IV infusion over 4-hour period. And subsequently, the maintenance dose will be 10 mg per kg that is given at a dose of 3 times a day. For the loading dose of IV quinine, even if the patient has acute kidney injury or severe jaundice, the same dose of loading dose can be given up to 48 hours, and subsequently then you can half the dose. However, if the patient has received quinine, received any form of quinine in the past 12 hours, then it is not recommended to give the loading dose of quinine, but to give the follow-up dose, maintenance dose at 10 mg per kg. The maximum dose of quinine that you can give in an adult is 2000 mg per day. For children, it's 1800 milligram per day, or the max upper limit is 600 milligram per dose. So you have to monitor pulse, BP, respiratory rate, and sugar from time to time because it causes hypoglycemia and hypotension. If you give rapid bolus of IV quinine, it might cause fatal hypotension. When there is a patient with severe malaria, we recommend you that you manage the emergency first and then provide IV artesunate, the first line or the second line of treatment, and stabilize the patient, consult the higher center, and do refer. What are the complications we expect in severe malaria, and how do we manage severe malaria in a tertiary care center? We will go one by one here. If it is coma, that's usually because of cerebral malaria. You have to check ABC, keep the patient in recombinant position, address the correctable things first, like hypoglycemia, or they may have bacterial meningitis. You might have to give antibiotic cover. If the patient is unable to maintain the airway, if the GC is low, you might have to intubate the patient. If there's seizure, do ABC, give IV or rectal diazepam, check glucose and electrolytes. If the patient is having hypoglycemia, check the sugar and give IV dextrose. If the patient is having severe anemia, please transfuse if it is less than hemoglobin is less than 7. And for acute kidney injury and for metabolic acidosis, the patient might require hemodialysis. For acute pulmonary edema, you'll have to prop up the patient, provide oxygen, stop IV fluid, give diuretics. Patient might require positive airway pressure or invasive mechanical ventilation. If there's bleeding or coagulopathy, you will have to transfuse fresh frozen plasma, platelet, or provide vitamin K. If the patient is coming with shock, manage it as per the septic shock protocol. Draw the blood culture, add broad spectrum antibiotics on top of your antimalarials, and then patient may require vasopressors. This slide summarizes which are the common features of severe malaria that occur according to the age category. For adults, the common features include jaundice, acidosis, and coma. Here on this side, for children, usually it is more about shock, convulsions, and anemia. The guideline classifies malaria death as a fatal outcome caused by malaria infection and its complications. So the complications that we have just discussed. And in every case of malaria death, a death investigation will be done. Now we will briefly discuss about the adverse effects of the common antimalarials that are covered in our guideline. First one is chloroquine. The adverse effects include pruritus, headache, some hepatitis, nausea, vomiting, skin rash, and rarely seizures. If there's known hypersensitivity to chloroquine or any aminoquinolone compounds, please do not give chloroquine. The adverse effects of primaquine are usually abdominal pain, rarely hypertension, some arrhythmia, and most important one is hemolysis in patients with G6PD deficiency. So if the common side effects of coartem is nausea, dizziness, and headache. And we have had some instances where the patient has vomited out the coartem. So in this case, please provide antiemetics and then re-administer the same dose. If there's known hypersensitivity to either artemether or lumefantrine, please avoid coartem. The adverse effects of artemether is hypersensitivity, gastrointestinal disturbances, some reticulocytopenia, neutropenia, and raised liver enzymes. If there's known hypersensitivity to any artemesin derivatives, please do not administer artemether. The adverse effect of artesunates include hypersensitivity, GI disturbances, and then it may also cause dose-dependent neutropenia. So for quinine, the adverse effects include synchronism, that includes tinnitus, headache, blurred vision, hearing change, nausea, and diarrhea, and it will cause postural hypotension, hypoglycemia. That's why you need to be very cautious while delivering quinine. And if there is known hypersensitivity to quinine or any of the synchronal alkaloids, please do not administer quinine. Now the question is that for Plasmodium vivax and for mixed infections, the treatment duration is for 7 days. And do we need to keep the patients admitted to hospital for all 7 days? The guideline recommends hospital admission for at least 3 days. And for the remainder of the dose, you may initiate the directly observed treatment protocol and then send the patient home. For DOT therapy, we recommend you to identify one person in the family or in your village health worker or some responsible guardian who will make sure that the patient consumes the entire course of the therapy. You will have to hand over the responsibility of delivering and completing the DOT therapy to the patient guardian, and then tell them that at the end of DOT therapy, which will be at day 7, you will have to come to the hospital and then do a smear to check for the clearance of the parasite, and then tell them that the subsequent follow-up will be on day 14 to 88, 3 months and 1 year for Plasmodium vivax. And after the completion of the 7-day DOT therapy, the medical officer in the hospital has to complete the completion report for DOT therapy and send the report to the program. We will discuss briefly about some special situation where if there is HIV co-infection, artesunate with sulfadoxine and pyrimethamine is not recommended. If the patient is on tremoxazole, if available, zidovudine. Artesunate amodiaquine is not recommended if the patient is on efavirenz. And if you are suspecting artemesin resistance, especially for Plasmodium falciparum, in patients coming from with travel history to in geography regions of the world where there is increased resistance, in this case, you might consider giving artemether-lumifantrine combination therapy for a little bit longer duration, up to 7 days, or you will go for other combinations or your second-line agents. We're coming towards the end of the presentation now about if a foreigner wants to travel across Bhutan and if they ask about malaria prophylaxis, if they want to travel certain parts of Bhutan, our guideline says there's very minimal risk of you getting malaria from Bhutan and malaria cream prophylaxis is not recommended. And despite this, there are other malaria-borne illnesses. Therefore, bite prevention measures are very important. So I will quickly discuss one slide on malaria case classification. This is important because as clinician, we would have diagnosed the case, managed the case, and sent the patient home, and we think that we have done the job. But for the malaria program and the Department of Public Health, the Ministry of Health, there's a lot of work to do. The Ministry of Health and the malaria program, they conduct one activity called as malaria case classification for epidemiological purpose. So we need to know the definitions here. In Bhutan, we have very low number of cases of malaria now. A malaria case, PV or PF, is classified as an imported case if the infection was acquired outside the country, a country of which it is diagnosed, and it is diagnosed as introduced if if the case is acquired locally, but with a direct link to the imported case. This means that person A has imported it into Bhutan, and person B gets from person A, who is an imported case. And now, if the case goes on to the third person, to person C from person B, which was an introduced case, then this will get classified as an indigenous case, and then it will be a second generation transmission, and this will be a local case. We have another case classification category, which is called as induced case, where you may acquire malaria from blood transfusion. The last part here is on malaria prevention. We need to keep our surroundings clean, avoid breeding sites, use long-lasting insecticidal nets, especially among the population living in the southern belt, especially our farmers who spend nights in the makeshift tents guarding their crops, and the program conducts indoor residual survey with insecticide. And for an individual, topical repellents are recommended. Overall, the culprit is the Anopheles mosquito, and we either have to avoid it, prevent it from breeding, or prevent yourself from getting bitten. Thank you very much for your kind attention. The contents were drawn from the National Guideline 2024 edition and the WHO Malaria Guideline 2023.